natural passive immunity would be an infant who picks up an antibody through the placenta or through breast milk, through breastfeeding. That's why it's so important to breastfeed throughout infancy. That all those pathogens and all of that breast milk nutrition and all that stuff that's in there, that child doesn't have developed. And passive immunity eventually goes away. So it's really good to continue to breastfeed children for a long period, not for a long period of time, but for their development stages until they have their own immune system to really protect them. That's why it's such a big deal. That's why it's always encouraged by almost any pediatrician you go to will say, if you don't breastfeed, you're crazy, you're out of your mind, because your kid's going to get sick. Just from that natural passive immunity that they build up. But that natural passive immunity will eventually fade away until the child has their own active that they're going to acquire. So an active, like let's say a natural active immunity would be chickenpox. You got exposed to chickenpox, your body built antibodies to fight it, it remembers that, and it's going to last for the rest of your life. That's never going to go away. That's an active, and that's a natural active. You can have an induced active would be like a vaccination. I give you a strand of a dead form of a virus, your body's going to build antigens to it and antibodies. It's going to build antibodies. It's going to remember that, and that's going to give your immune system that boost that you need. A passive active immunity, induced passive immunity would be like if instead of giving you a vaccination, I just gave you the antibodies. Your body never built the required memory, so eventually that immunity is going to go away. So whenever you think of passive, think of it as short term. They don't last forever. Where active is always for the rest of your life, you'll have immunity to that. Now some of you guys, when you went to do your physicals here, you had your titers checked. And if your levels were too low, you got like booster shots. And that's only because, just in case. If you didn't get those booster shots and you got exposed to that bacteria, you may get sick for a little bit, but your immune system would definitely take care of it, and you wouldn't have the full effects like you normally get. You may just get a fever, or you may just get congestion or things like that. But it's really important to get those titers checked, yes.
Like if you get the chickenpox vaccine, and you could have gotten chickenpox after that vaccine, just not the full effect. You could have probably had an issue going.
Your body would kill it before it would have that full effect.
Right, so you could have still some symptoms. So it's possible that you could have had chickenpox as a kid and not even know it because there was underlying due to vaccination.
Right. Yeah, your immune system's really weird, really complex. And then it does weird things like attacks itself. And that's where we come in to treat anaphylaxis. But it's good to understand how basic immunities work. So that's the general concept. That's the immune system crash course. Understand the basic concepts of it. Big thing versus what's that? Kind of. If you're talking about comparing it like an allergic reaction to it. So what happens, the difference, I mean, that's its own, essentially what happens is you get a virus like HIV. HIV will also live in nerve cells, and it also takes over T cells. Well, T cells, remember I said I was a macrophage going around, looking at different bacteria, so I'm a macrophage. I check this pathogen, I like this one. Oh, I don't like this one's bad. Let's send a T cell to come kill it. Well, it sends that T cell, and it takes the virus, attacks the T cell, and takes over, so it can't kill it. And then it starts multiplying inside all those T cells. And now, anytime you have a different pathogen come along, let's say pneumonia comes along, I go around, I scan everything, I look for those receptor sites, and all of a sudden, I don't like this bacteria, we need to attack it, but I don't have anything to attack it to. And that's where AIDS, that autoimmune deficiency comes, because there's no longer any T cells that are going to come around because they've all been attacked by the HIV virus. And that's why you die from other complications. You don't actually die from AIDS. AIDS does not kill you. It's the other viruses. I mean, AIDS kills you because it's taking over your immune system, but that other, your actual, like, if you went to
common cold.
exactly, you die from influenza, because that's what the common cold virus is. So you would have influenza, you'd have pneumonia, you'd have staph infections, all those things is what your, what are they called? go to a morgue, as a mortician, but before you go there, medical examiner. Medical examiner would write down that your cause of death is actually staph infection. Like, for example, when you get a really bad burn patient, most burn patients actually, they die from all the compromises of burns, but as far as to a medical examiner who goes around, they go, oh, you had a staph infection because you're immunocompromised. And they'll put the cause of death to be from staph infection, which isn't really true. You died because you had multi-system trauma. It just so happened to be that's what caused your pneumonia that killed you. Not the third spacing of fluid and the extreme burns and everything else. That's just medical terminology shit. So. All right, so getting into other aspects of this. Hypersensitivity, you guys learned about this when we were going through drug cards. And this could be all different types of things. Now, you can have a patient who says, oh, I'm hypersensitive to a medication. Let's talk about aspirin. It gives me really bad stomach pain. That's not really even hypersensitivity. That's just a side effect of the medication. Other hypersensitivities may be, for example, oh, well, I take labetalol. Instead of it lowering my blood pressure a little bit, like I completely pass out and go unresponsive. I think I told you guys about Instructor Parks' situation where they had a patient with hypersensitivity to adenosine. So much that instead of having that normal 6 to 10 second response, it was like closer to a minute, which is awful, terrifying, but that's the hypersensitivity. He then tells the hospital about this hypersensitivity because it's not an allergic reaction. They're not, the body's not attacking itself, it's just the medication works so well. And the hospital didn't believe we gave the medication, same thing happened to them. So, sometimes you'll see some rashes, but normally once you have a rash actually develop, that's not so much hypersensitivity. Now we're getting into an allergic reaction. So be careful when you kind of see a rash or something like that. More of hives. Think hives that's an actual allergic reaction. Where when you just get kind of a slight rash, like what I get from when I drink like a bourbon-based alcohol, that's more of a hypersensitivity. But if that rash got any worse, definitely would be considered an allergic reaction. So they kind of go hand in hand. They can be slightly used interchangeably, but once a hive starts to develop, it's no longer a hypersensitivity. And you can have all different types of reactions with hypersensitivities, idiosyncrasies and things like that, like odd things. Like if I gave you a medication like labetalol that's supposed to lower your blood pressure, you may have an idiosyncrasy that it actually increases your blood pressure. That happens. There are crazy things like that where people have opposite effects of certain medications. So you always have to be very careful with that. All right, so allergens. The big thing you guys need to understand about this is that release of histamines, of heparin, and histamine is what actually causes the hives themselves to really form and then causes that vasodilation, where heparin obviously is a blood thinner, so not so much really a dangerous thing. It's not going to be the point where you're actually going to start bleeding, but it's part of the side effect of it. The histamines, they're essentially responsible for your bronchial constriction, your wheezing you're going to get. You're also going to get like bronchial increased secretions. So anything that's going to cause this vasodilation, this gastric mobility, increased vascular permeability, vascular dilation, you're going to get other fluids along with that, and that's where that angioedema that you see down there at the bottom, and that's the swelling of the face and everything like that. Yeah. So the reference that we use is that face from Will Smith and Hitch, where his whole face swells up, and it can be that bad. It can be that extreme. Do you guys ever see the episode where Bear Grylls gets stung by a bee? It's pretty fucking impressive. It is a great documented case of allergic reaction. The man can drink his own urine, but he gets stung by a bee, he almost dies.
You have this in the book or no? Which book? Yeah, all this. Jesus.
That looks bad.
This is fake? It looks pretty legitimate.
This?
It looks pretty new.
He's trying to get food.
He just sticks his hand in.
normally a secondary response. These things change too.
Oh, right.
Never let me do
I like the other guy.
See this thing here?
And the system start.
That's what you want to put out. You can see that? And that's where they deliver it. But, you know, one sting for a load of honeycomb isn't too bad. Quite brutal.
How's that honeycomb taste?
The other man says it's quite hard though. It's starting dying. Try comparing to a bit of honey. You risk nothing.
Risk nothing, gain nothing.
A lot of risk right there.
Yeah, that's so bad.
Alligators I've dealt with over the years.
That's all it is.
Pretty ironic. Look how small. Jeez. That's the angioedema we're talking about right there. Pretty big sample. I don't know. I don't know what happened. All I know is that is awesome. There's a lot of whole theories about that whole thing being fake. Not the bee sting, but like he goes to the sites and knows his whole pathway and all that. Which one of the survivor man's the better one of the two? Because he's got to film everything, so he's to do everything twice. And he's got to carry the cameras and shit like that.
He found a random motorcycle that worked perfectly fine in the, like the desert.
Bear Grylls?
No, the Survivor.
Yeah, that ship is sailed. But anyways, everyone obviously just got a good example of that angioedema. All right, so anaphylaxis. Now this is the systemic aspect where that pathogen has now has sent our immune system completely haywire, and now we no longer just have that localized rash, we have a full anaphylactic reaction. This is an immediate life threat, so now you have parts of the body that are actually going to shut down. This is fully affecting your cardiovascular system, so you're going to have complete vascular dilation. So this patient's going to be hypotensive. So if we go and give this patient IM epi, right? So we go, okay, we draw 1 in 1,000, 0.3 milligrams, and we give it to this patient who's in anaphylaxis. It's not going to do anything. It's not going to work because the patient has so much vasodilation that there's nothing to pull. There's no vascular resistance to grab the medication out of the muscle. So we have to give that medication directly to that patient's vein. So that anaphylaxis, this patient's going to get epi 1 to 10,000. For an allergic reaction, the patient has a localized rash, hive, some bronchoconstriction. Before it gets to the point of an allergic or a severe anaphylactic shock, we're going to give that patient IM epi. Everyone understand the difference between so once they're completely. Go ahead, Mr. Question.
Is it like stable and unstable? Is that like?
Essentially, yes.
And then just blood pressure is basically what you're looking at to determine.
You're not going to have just blood pressure. You're going to get the full gamut,
Yeah,
and it's
no,
going to be extreme.
yeah.
But once their vascular system's been compromised, that's kind of the checking point where we no longer try to give medications that you must give because they're not going to work. So that's the big thing for us is just the medication routes. So once they're hypotensive, they're compromised, we're going to go ahead and give epi 1 in 10,000 thing, which is really rough on the heart.
The same dosage, just regular active as you give IM.
It's still 0.3, but it's diluted. So, yeah. And you never get epi 1 in 1,000 through the vein. You never do that. Really, really harsh on the heart. I mean, it may survive, but depends on the patient's age, especially in an elderly patient. There were some other questions. Good question.
Sorry, so can you repeat the dosage again?
For which one?
0.3?
It's
1
0.3 milligrams. Now, that little medical packet you guys have, I think there's a range to it because they're different departments. Some departments only give 0.1, some departments give 0.5. There's a range to it. So 0.3 is normally the common range for both of those, epi 1 to 10,000 and epi 1 to 1,000. 10,000 is always in a vein, 1,000 is always in a muscle. And again, that's normally based off the cardiovascular side of things. Now, you'll have wheezing and things like that and an allergic reaction, and it can be really bad wheezing. And that patient will be fine with an IM medication. They're not in a full anaphylactic aspect yet because they're still are vascular compromised. As far as GI secretions, definitely patients normally are nauseous, vomiting, diarrhea, and the body's doing everything it can to get rid of this pathogen, yes.
So like, if the patient has their EpiPen on them, and they're going into anaphylaxis, you just want to start IV with your own, or would you still try to?
I mean, you're looking at a time thing. If they have an EpiPen on them, hopefully they took it before they called you. You know what I mean? Normally when we show up, it's to the patient who doesn't have an EpiPen. Or they already used their EpiPen and the allergic reaction's already subsiding. This is normally how that goes. If they have an EpiPen, they tend to use it because they're terrified because they've experienced it before. They know how awful this whole process is going to be. We already talked about the skin. So, normally caused by injections, but again, food allergies and everything like that are really, really predominant. And they can get really, really bad, especially peanuts and tree nuts and things like that. But you're going to see all of the effects. You're not going to just see a cardiovascular compromise. You're going to see everything. This patient's going to be circulating. You're going to start to go unresponsive. It's going to get really, really bad. Any questions on signs and symptoms? Being able to differentiate between the two, and as far as medication stuff? All right. So as far as our assessment goes, focus history, because we're trying, this is something quick, we have to fix this right here, right now. And as soon as you start to kind of have something like the tongue starting to swell, whenever you have an airway issue, you have a patient who, so let's say that this patient has bronchoconstriction, wheezing in all fields, you listen to long sounds, they're not moving a lot of air, they have some hives, that's still just a general allergic reaction. That's an allergic reaction. It's a severe allergic reaction, but it's not anaphylactic shock yet. So that patient would definitely get epi in the muscle, so they would get 1 to 1,000. Things like their tongue starting to swell is definitely something, okay, I'm going to give epi, but I got to find out what route. If their tongue is swelling up, things like that, we're really getting to the point where we're going to start getting to an anaphylactic shock. Now, the patient just hasn't progressed to that point yet where they're vascular compromised. So you get to make a decision, normally a decision is based off of blood pressure for almost every fire department, EMS agency, they always base it off of that. But we're doing our assessment. Big thing here is definitely, this is one of those times where that last intake really comes into play. Okay, well, what was the last thing you ate? What were you doing when this happened? This reaction is normally not a delayed reaction. Normally people don't have allergic reactions 4 or 5 hours down the road. It's almost an immediate response. Something goes in their body, they don't like it, and you'll notice it right away. Like in my situation where I get a light rash, I can taste it in the alcohol. I taste the metallic taste right away, and I know every single time. So, and it's not anything super concerning. It's just one of those things. And these patients are exactly the same way. They've been through this allergic reaction before, so they definitely can isolate and tell you whatever either happened or what they ate. OPQRST really isn't so important in here. I don't know why I put it in there. The onset, it's going to be sudden. Is there anything that makes it feel better? Yeah, not taking fucking pine nuts and eating them. That would make me feel a lot better. I mean, there's nothing in there that in an OPQRST that's pertinent towards this patient's history. So I wouldn't even, if you can get one of these patients, it'd definitely be fine. As far as our physical examination, respiratory difficulty is a big thing. We need to treat the respiratory issues right away. So as soon as you start hearing any wheezing, first thing you're going to want to do is do a breathing treatment. Normally it's just albuterol. Some departments do albuterol and Atrovent, or they'll do Soconex or albuterol. But for us, any breathing treatment will be fine. Preferably I just albuterol. So sometimes less is more. Albuterol works really well for this. I think that's what your guys' packet says too. It's just albuterol, right? So it's listed there for allergic reaction. So yeah, you can give Soconex, you can give albuterol. It doesn't make a difference. Albuterol is probably the easiest one. You guys have that in your box, and that's going to fine, give a second breathing treatment if you have to. If it's not working, well, now we need to get more aggressive, now we need to go ahead and start considering giving epi-IM. Because that respiratory difficulty can get worse very quickly. So, this chart from your book, there's a whole bunch of signs and symptoms. And again, you guys should probably already know all of these, nothing here to really jump out at anything you didn't know, but hives, urticaria just means hives. It's an interchangeable term. For some reason, it gets forgotten a lot. As far as bowel sounds go, don't listen to bowel sounds, it's just ridiculous. Your patient's definitely gonna have increased gastric mobility, so they're gonna be nauseous, they're gonna be vomiting, and they're probably gonna have diarrhea. Any questions on any signs and symptoms of anaphylaxis or allergic reactions? Alright, so as far as scene safety goes, the biggest thing as far as scene safety would be, I'd say, bees with an allergic reaction call, especially if they're Africanized honeybees. Africanized honeybees, essentially, if anyone ever deal with them and you're seeing Africanized honeybees, it is no joke, they are mean as hell. But they're the same exact species of bees, they're not any different than standard bees, like honeybees that you see. The big thing with Africanized honeybees is they are just super, super aggressive. And you'll see swarms of them and whatnot. But their stings are exactly the same, they're not any more potent, but they won't leave. They will stay until, like, if you jump in your car and just wait for them to go away, they're not going anywhere. They will build a hive on your car. They are ridiculously mean. Most fire departments tend to have SOPs for, like, using foam. You guys have that for Tom Rich? Yeah, bee suits, yeah, but foam kills them. What's that? No, what you got?
No, what you were saying, what the bees are on your fur.
They took them off our rescue, but I know we did have these.
Yeah, there's no reason to be that close that you need bee suits. We had bee hoods and tape and all this other shit, but foam works really well. They can't fly, but they put foam on them. So, yeah.
Like a fire.
No, like foam you use. Yeah, anything like that. Just soap suds. They can't fly. I don't know how it works, but they'll just be in a pool. Something like that, sure. Yeah. They get stuck in the foam and they drown. Fire. As far as scene safety, really it's just bees. As far as like a man of war or a jellyfish, just removing it. I mean, it's not like the jellyfish is gonna jump out at you. So there's, even snakes can cause different types of allergic reactions and whatnot as well. Whenever you're dealing with any animal, obviously animals are unpredictable. As far as airway adjuncts, be cautious in using certain airway adjuncts. Like, for example, if they have really bad angioedema, like Bear Grylls, may not put an NPA in that patient. That patient may just be fine with just a breathing treatment and some Benadryl. In severe cases, obviously, if the patient's going unresponsive, they're in that anaphylactic shock, that's when we're going to consider intubating and things like that. But before we do that, epi 1 in 10,000 is the way to go. As far as surgical airway, most of these patients who are in anaphylactic shock normally respond pretty quick to epi 1 in 10,000. Crikey somebody before you give epi 1 in 10,000. If you give epi 1 in 10,000 doesn't work, absolutely. I would be I guess the best way to put this is start setting things up and have them prepared as you're giving your medication, and if they don't start to respond to that medication right away, try it. If there's no gas exchange, you get to the point, if you've gotten there too late to where they're completely closed off, and nothing is, you go to bag and you're just getting complete resistance, then obviously, yeah, you need to try that patient, because the sooner they have some sort of air exchange, the better. But I'd be cautious of doing it before giving epi. Never seen an allergic reaction not respond to epi. If it doesn't work, if epi doesn't work in a patient who is in an allergic reaction, what would stop epinephrine from working? What was it? Beta blocker. Exactly. So this patient has beta blockers, so we're giving medication that's just being blocked. So you can give something like glucagon. Other ones haven't worked that much. So you give 1 to 2 milligrams of glucagon. Well, actually, it's not an antidote. It just causes the epinephrine to start working through inotropic effects. it's a side effect glucagon, is really what it comes down to. So as far as IV access, your patient's gonna be hypotensive, they're gonna be third spacing, so they respond really well to fluids. They can be lactated ringers or normal saline, doesn't make a difference, normal saline is fine. But they will begin to become volume depleted just from the third spacing alone. And part of another, it's like a, so not only they're vasodilated, but the third spacing, those two components working against that patient's blood pressure. So they respond really well to fluids. Just some differences between mild and severe allergic reaction. As soon as essentially, I would base this off of bronchial constriction. If they're moving plenty of air, they just have some slight wheezing, and they can just take a breathing treatment and some Benadryl, that's a mild allergic reaction. Now, you gotta listen to lung sounds, and they're tight, and they have wheezing all over, but they're not fully affected to the point where they're vascular compromised. That would be more of a severe allergic reaction. Once they're vascular compromised, now we're talking anaphylactic shock. So that term anaphylaxis, I would just, every time you guys say it, I would associate shock with it, just so you always remember and associate it with blood pressure. Let's see. Nothing else on me really jumps out that shouldn't be too obvious at this point. You guys should have a pretty good understanding of allergic reaction. And here is a super bike medic administering to a kid. At least I'm assuming that's what he's administering. So obviously determining your scene safe, making sure there's no bees or other animals that are there. Protecting the patient's airway, ABCs shouldn't change, should be no different. IV access, standard stuff. You can get IV access while you're still giving medications IM, by the way. So obviously it depends on what condition the patient's in. If the patient's hypotensive, you need to get that IV a lot sooner because there's no point in giving any medication intramuscularly.
Stretcher on the back of his bike?
What's that?
Is he have a stretcher on the back of his bike, or like?
No, normally when they do like public events and stuff like that, they have bike medics out, different things, different parts out. And then they wait for the rescue to show up. So, treatment as far as medications go, antihistamines and epinephrine are primary treatments. If we give epinephrine to a patient, even though we haven't given them a breathing treatment yet, the patient will still definitely benefit from that. It all depends on where they're at and as far as how far that allergic reaction's really progressed. So the first treatment that we should always do is obviously oxygen. So if their breathing has been compromised or their airway is compromised, whether it's a non-breather or BVM, doesn't make a difference. It depends obviously on the patient. The dose we have referenced here for epi 1 to 1,000 is 0.3 to 0.5. As far as giving a medication sub-Q, no real point in doing that, just give it intramuscularly. Straighten the muscle, it works a lot faster. Now, if they're hypertensive, we're going to give it in the vein, sub-intravenous, or IO even if you have to. Antihistamines can be given intramuscularly or intravenous, doesn't make a difference. Solubenadryl, those corticosteroids are very beneficial to these patients. The problem with corticosteroids is they tend to not work when we give them. What I mean by that is the duration of care, by the time we get to the hospital, they're probably just then starting to kick in. So it's a good thing for the patient, but you're not going to see any benefit from it. So don't prioritize corticosteroids over a medication like epinephrine or Benadryl. So give epi, give Benadryl, then you can give the solubenadryl while you're transporting that patient to the hospital. As far as vasopressors go, some departments have protocols for things like an epinephrine drip, and that'll be secondary to, he's an ow. You not see that? I'm just standing in the back room. It's all right, but it happens to the best of us. So vasopressors, some departments will do a vasopressor, so they'll give like epi 1 to 1,000 IM, and the patient's still not responding 100%, they'll do an epi drip. They may do 2 mics, they may do 1 mic, it all depends. It's not really that common locally here. You may see some hospitals do it after long-term care. As far as beta agonists, things like that, when you start dealing with patients who have beta blockers, those tend to be the elderly patients who have allergic reaction. They don't respond to albuterol, they don't respond to epinephrine. So it's really important to get that sample history, find out what medications they're taking. Oh, you took atenolol. When did you take your medication? 2 hours ago? Well, yeah, epi's not going to work. The only medication that's going to work is Benadryl. So you have to give the medication like glucagon to kind of bypass that. Psychological support. Obviously, these patients are going to be pretty distraught. Like I was telling the story about the guy that I work with, when he has allergic reaction, it's awful. He turns to like a whole different person. It's like a monster. So psychologically supported is not such an easy thing to do, especially when he's waking up in the back of a City of Miami fire rescue ambulance and they want to transfer him to the hospital. So you got to be tactful with those things. As far as prevention, obviously education. Once a patient kind of has an allergic reaction, they try to find out what it is and they avoid it at all costs because it's a terrible experience for that patient. As far as patient education, really we don't have to do this that often because they understand that they're allergic to it. It was an isolated incident. Oh, well, I didn't know this this food that or this candy bar I just ate had peanuts in it. It said that I looked at the label, it didn't say anything. Those things are just going to happen, those are just flukes. And those are normally the calls that we get called to. The most important thing that I want you guys to really get out of this lecture is that this is one of those emergencies that we definitely play a very important role in. The cool thing about this is one of those situations where you start to treat the patient and you completely see a patient that was borderline on the cusp of death completely come back to life and be completely fine within the duration of our care. So it's definitely important that you guys are very confident in understanding when to give what medications and how they benefit the patient, because this is definitely a call you will get, you will run, and you're directly, it's just not, you don't run calls that you save someone's life every single day. This is one of those calls where you really are, because that patient will die if this progresses. So, just kind of something that's neat. All right, an example of natural passive immunity is so we got a little bit of a confusion here, but yeah, so the right answer is obviously breast milk. As far as antibodies that develop after you've been exposed to something, that's an active immunity. So you've been exposed to this pathogen, your body builds these antibodies and it reserves them, and then if you ever get exposed to it again, you're now going to be safe because it's going to attack that bacteria or that pathogen with those antibodies it's already made, so that's an active immunity. Really screwed you guys up, huh? All right, so at what point should a patient receive epi 1 to 10,000? Now remember, 10,000 is diluted so that it can always go in a blood vessel or go in the vascular system. So this is going to be based off of hypotension. So if the patient's hypotensive, we give epi 1 to 10,000. If the patient has a swollen tongue, I'm definitely concerned. I'm definitely going to treat that patient with epi, but I'm not going to give it intravascular if I can give it intramuscularly. Same thing with wheezing. So if I have wheezing, diminished lung sounds, and not moving a lot of air, definitely concerned this patient's on the cusp of going into severe anaphylactic shock. But if I give the medication intramuscularly, it'll still work. So, as far as hives, not really so much worried about hives. That's just going to be localized. It's going to be beneficial. Any questions? Anything allergic reaction based or immune system based? No? All right, go to lunch, food bag, 1:15.